Hello everyone. Welcome to the OBSSR Directors Webinar for January. It's titled Community Partnership for Healthy Sleep. I'm Bill Riley, Director of the Office of Behavioral and Social Science Research here at the National Institutes of Health. Before I introduce today's speakers, I'd like to mention just a few housekeeping items. Today's webinar is being recorded, and a recording of the webinar will be available on the OBSSR website in approximately 1 month. Today's presentation will be followed by a question and answer session. All the phone lines will be muted during the webinar. Questions and comments will not be taken by phone, but will be taken by the Q&A feature, which, if your screen looks like mine, is on the bottom right corner of your screen. And you can click on that Q&A, select all panelists, and type in your question and hit send. You don't have to remember your question until we get to the end of the presentation. You can type them in as you hear them and think about them, and once we get to the end, I'll moderate questions for our speakers and presenters today. Okay, so today's speakers, I'm really pleased to introduce both Drs. Nancy Redeker and Dr. Lois Sadler. Dr. Redeker is director of the NIH-funded Yale Center for Sleep Disturbance and Acute and Chronic Conditions, and the YSN Biobehavioral Laboratory. She has a sustained program of research conducted over more than 25 years, which addresses the role of sleep and sleep disorders among patients with acute and chronic conditions and the effects of behavioral sleep promotion interventions for clinical and community populations. Her co-presenter today, Dr. Sadler, is professor at the Yale School of Nursing, where she teaches master's and doctoral nursing students in the areas of family studies, child development, pediatric health promotion, and other topics. Her research interests include the evaluation of specialized support programs for at-risk young parents and their children. Her publications and presentations are on adolescent primary health care issues, community-engaged research, high-risk families, adolescent parenthood, and home visiting. In 2014, their home visiting program called Minding the Baby, which was developed and tested with colleagues from the Yale Child Study Center, was designated by the Department of Health and Human Services as an evidence-based home visiting model, one of only 17 models of such nationwide. On the topic of community partnership and healthy sleep, let me introduce Dr. Redeker and Dr. Sadler.
Thank you so much, Dr. Riley. We're delighted to present today, and this is a great example of an interdisciplinary and community-engaged partnership. So the way we'll do this is I'm going to present about the first half, which will be the methods, and Lois will present our findings to date. This is a project that's in progress. We've completed about almost 1.5 years of the 2-year R21, and so this is by no means the final word, but I think we're going to talk today about where we think we're headed with these interesting data that we've collected. So I'd first of all like to acknowledge our partnership. Obviously, we can't do community-engaged research without excellent community partners. Our partners include parents residing in the greater New Haven, Connecticut area, which is a very ethnically diverse as well as socioeconomically diverse community. Our providers and pediatricians within the Yale New Haven healthcare system and the primary care center, which is specifically the clinical setting that serves particularly low-income families in the community. We've also reached out, although it wasn't in the original grant, and we'll tell you why. We were including child care providers in the community, as well as our YCCI cultural ambassadors. The YCCI is the Yale CTSA that has done, and Lois has been involved in a lot of this, in a lot of outreach into the community, and the cultural ambassadors are the community representatives that work closely with the CTSA, who've been instrumental in helping us with this project. The other group I'd like to recognize is the Junta for Progressive Action, and that is a group in the New Haven community that advocates a lot for Hispanic and Latino populations. A lot of the people that they serve are also immigrants in our community. Our Yale team includes Dr. Sadler and myself, of course, Megan O'Connell, who's our program manager, Monica Ordway, who's a very promising young faculty member, has another related program of research looking at the idea of stress, biological stress and sleep in these young families. Nancy Benaziak, who's a pediatric nurse practitioner, as well as Angela Crowley, who's done extensive work in community child care centers, and Dr. Ada Fennick, who works in pediatric primary care at the PCC, and Dr. Craig Kenneth-Perry, who's a pediatric sleep specialist. And so our ongoing collaboration, a large part of this project has been about building this team so that we can go forward with more work in the future. So basically, just to give you a little bit of background, as we are increasingly aware, healthy sleep is critical to children's health. We particularly know that sleep difficulties are common in young children with irregular bedtimes, short sleep duration, nighttime awakening, and bedtime resistance. There's quite a number of epidemiologic studies showing that young children, particularly children that live in families that suffer from socioeconomic adversity, have shorter sleep than what we've decided, what have been determined to be normative level. These children should get from 11 to 13 or 14 hours a night. Some of our early data suggests that they're only getting about 9 hours of sleep at night. And the basic premise of our project is that sleep difficulties begin early in life and that they may persist over the lifetime. We know that persistent sleep difficulties are associated with negative health outcomes across the lifespan. For children, we know that they have a negative impact on behavior, school performance, mental health, and there's increasing evidence that poor sleep over the lifespan is associated with obesity, metabolic disorders, and risk of injury. And so the basic premise of this project is if we could do better with sleep promotion at an early age, could we improve other outcomes over the longer term? So we know that economically stressed families are more vulnerable to sleep difficulties and that there's enormous disparities in sleep health as well as health care. These are just a few of the publications. There are quite a few more that are beginning to show that. We also know that existing sleep promotion strategies may or may not be relevant and feasible for some of these families. For example, a major focus of some sleep promotion has been on modifying the environment. Well, depending on the family's environmental circumstances, that may or may, what we're proposing in a standardized way may or may not be possible. There are also a lot of cultural variations in how people sleep or what they think about sleep, and that's also a focus of our study that we are conducting. So the idea here is that we're reaching out to another. There are already quite a lot of sleep promotion interventions out there, but most of what's known has been in sort of middle and upper middle class families. So our focus is on those families that suffer disproportionately from sleep disparities. So our work is really framed within the social ecological model that suggests that child sleep patterns occur within context. And the context that we focus on here are the family, and we know that sleep is an important part of parenting. It's a part of way parents interact with children, especially at a young age. There are family sleep rituals and parenting practices. Beyond that, we have community factors such as the environment. For example, if families are homeless, they live in crowded housing, noisy families. Families have already told us that some of them have irregular work schedules. If mom, for example, does shift work and has to move the kids around at night, how does that impact on their sleep? And also the idea of bed sharing. Are there enough beds in the house? Are they comfortable? Is it quiet? All of those kinds of issues. And then beyond that, we see that there are differences in cultural or religious traditions that might influence sleep, including practices that may help or not help sleep. Singing, praying at bedtime, giving a bath, massaging the skin, all of those kinds of things may go into what we learn during our youth and how we influence sleep in children. And so the focus of our study, which has many qualitative components, is on understanding this context. So the American Academy of Sleep Medicine has produced practice parameters for pediatric sleep. And not to go into the gory detail here, but basically the idea is, what do you do at bedtime? The child doesn't want to go to sleep. What do? Do you leave them in the room and have them cry? Do you do it suddenly? Do you do it gradually? What do you need in terms of a bedtime routine? Things like taking a warm bath, reading a story, saying a prayer, and included the idea of parental education that prevents negative sleep behaviors. Now, these are practice parameters based on some pretty good science. But the question we have is how feasible are these, and how can we deliver these kinds of known interventions to families that may be of limited resources and limited means, and where there might be cultural parameters that influence their ability to do these things, or even their awareness that these things are important. So really our question is, under what conditions would these work, and how should they be delivered to these families? So we do know, just to give you a brief overview, there have been several reasonably conducted clinical trials that have looked at sleep promotion. Again, all of these, the first two here have been done primarily in middle and upper middle income families with needs. The first study done by, and these are two papers reporting the same study. One was short-term and one was longer-term outcomes. They did internet-based sleep education for families with young children and showed that they were able to increase the duration and continuity of sleep. That is, the children slept longer and the sleep was less fragmented. That means fewer awakenings. And interestingly enough, in the second paper, they reported that the changes persisted at 1 year. Again, this was middle and upper middle income families. The second study, they used graduated extinction and bedtime fading. Basically, the idea is that gradually get the child used to going to bed at a certain time and so forth. So this was a small randomized controlled trial. The sleep problems were not very well defined, but what they did show was that they were able to improve sleep latency. In other words, the kids fell asleep more quickly. In the third study, which was simply an education class and a Head Start program, they showed short-term benefits. Again, so this was more similar to the population that we're interested in. They showed short-term benefits in sleep, but there was no persistent improvement. One of the possibilities for why there was no improvement, it was simply an education course without any continued interaction or guidance to the family. So we built this project on some preliminary work that we had done. I had worked with a colleague in Newark, New Jersey for a number of years when I worked there, and we conducted two studies looking at a population where the moms were, the first study was simply of women, and we were looking at sleep patterns and mental health issues as well as stress in women recruited through the Women's Infants and Children's Program in Newark, New Jersey. And what we showed, not to anybody's great surprise, was that sleep patterns, poor sleep, was closely associated with mom stress as well as patterns of PTSD and depression. In the second study, we were interested in not only the moms, but how does mom sleep influence the sleep of the children. And in this fairly small study, we recruited preschool children and we measured their sleep risk activity and mom's report. And in fact, the mom's mental health and the psychological status were closely aligned with the children's sleep. That is, moms who were more stressed had more mental health issues, their children had poorer sleep. Since this time, there's been a number of studies that showed that, and really goes to the point that sleep as a family is there, and mom's health is closely aligned with the kids' health. And then Lois's project, she's been doing ongoing work with parenting, and she can tell you a little bit more about her parenting intervention, which consists of home visiting with young economically stressed families, which represent the same population in which we're interested, and has looked at a number of mental health and other important outcomes in these families. So what we're doing here now is adding sleep to this mix. Then we have others on our team who have clinical and related experience that really goes to the strength of our team. Dr. Fennick and Benaziak are pediatric primary care providers and have, of course, been intimately involved in providing pediatric care to our community population. And Dr. Kenna Perry is our sleep expert, as I mentioned earlier. And then Dr. Crowley has done a number of projects with Head Start and other child care programs in the community, looking at things like safety and training of the intervention of the child care personnel. And then, of course, our community partners, and we'll talk to you a lot more about what our community partners have said about this project and how they've informed it. So basically, the purpose of this study is to bring parent, provider, and community perspectives to the development of a sleep promotion program that's tailored specifically to the needs of families living in economically stressed urban environments. The specific aims are to examine the parents' knowledge and perceptions about sleep in their 6 to 36-month-old children, and to look at their perceptions about sleep habits, sleep difficulties, the factors that are related to sleep, including those things guided by the social ecological model, the consequences of sleep difficulties, and perhaps most importantly, their preferences regarding how we might be able to help with sleep promotion. And then secondly, so we're looking at it from the perspective of the parents, but also from the perspective of the pediatric primary care and child care providers. Now, initially our project was designed only to look at the pediatric primary care providers. But in our very first meeting with the community, they informed us that we really should look at the child care providers. And you'll see in a few minutes that this has been an amazing contribution. It's really informed the work. And so we're looking at similar things in this population, this sample. How important do they believe that sleep is? What are the factors? And what are some of the successful and unsuccessful approaches to sleep promotion that they've tried with these families? So those of you in the audience that are clinicians know that in pediatric and other forms of primary care, there's very little time to spend with families or individuals on these issues. And so how does one find appropriate time and expertise to address day-to-day concerns about sleep? So that's been a primary point of our interview. And then finally, the third aim, and we're moving into that now as we get near the end of the funding period, is to collaborate with parents and providers to develop a feasible sleep promotion program. And then ultimately, of course, our goal will be to develop a community-based RCT to address that. So as mentioned with the social ecological model, we are using a community-engaged approach in which we're blending advice from families, providers, and the literature. And the role of the community and the stakeholders will be key to our ongoing success, but we believe key to our future success. So, and now I'm going to turn this over to Lois. Okay, so initially, when we were thinking about this project, we went early on to the cultural ambassadors, which, as Nancy mentioned, were the group of individuals from the community, representatives of different community agencies, as well as representatives from the faith community in New Haven, clergy, and church leaders. And we were able to present to them and sort of get their responses to some of our ideas about this project. Initially was, I think Nancy went to them early on just to find out if sleep was an important area of interest to them, or you know, would they be invested, would they be interested in working on sleep projects, and the answer to that was a resounding yes. And then we went back to them with some more of our ideas to get their responses and to hear their advice.
Lois, can I ask you to move a little closer to the mic?
Oh, sure. Sorry.
Thank you. That's all right. You're just getting down on us a little bit.
Okay. Is this any better? Is that better?
Yeah, that's much better. Thank you.
Okay. All right. So initially, we had gone to that cultural ambassador group for their advice and their direction. After hearing from them and after understanding from them that it was going to be important to include not just providers and families, but also child care providers, and also to think about how we could include Hispanic and Latino families, both families who were fluent enough in English, but also families who were Spanish speaking. And so we were able to add those components to the project. We also convened a Community Advisory Committee, the CAC, and this was a group of, sort of a subgroup of the ambassadors, where we could actually run the whole study and interview by them and sort of get their input, get their advice, They made lots of suggestions, and we were able to modify things so that we had a much more community-friendly project with their input. They were also helpful in identifying participants and ways in which we could recruit people into the study, and they were very helpful in linking us with not just center-based child care providers, early Head Start centers, other child care centers, but also in New Haven we have family child care, licensed family child care, and they have a consortium that's called All Our Kin, and they put us in touch with representatives of that agency. So that was very, very helpful. Okay. Okay. Let me see if I can advance this. Wait, I did. Oh, okay. Sorry. Sorry. Get rid of this thing. Okay. All right. Well, okay. So let me just go over the study design. So this is a mixed method study, and we're using a convergent parallel design. We have participated in qualitative interviews with our providers and with parents, and we are also administering parent surveys and conducting actigraphy with the older infants and the toddlers in our family sample. So the sample is purposive. We were deliberately looking to recruit about 30 or so multicultural parents of children between the ages of 6 and 36 months of age. We also had an original target of 30 pediatric providers and child care providers, but as we were both interviewing and analyzing our qualitative data simultaneously, we determined that we really reached saturation. We were hearing the same themes over and over again from our provider sample after about 16 or so interviews. We recruited primarily from the New Haven Hospital Pediatric Primary Care Center, and we have also recruited from 5 child care centers in the New Haven region, including home-based and center-based child care. One of those center-based child care centers is in a high school and specifically serves teen parents and their children. So that sort of gave us an additional bit of insight. We obviously had to get IRB approval through various layers of the Yale system, the pediatric primary care system, and have informed consent for all of our participants. Go to the top. All right, our slides are having some. Okay, here we go. Okay, in terms of quantitative data collection with parents and children, we are giving them surveys, collecting some background demographic data and health information. For the parents, we're asking them to complete the short form of the Parenting Stress Index and the brief symptom inventory, which is a mental health inventory. We are giving the sleep questionnaire, the brief infant sleep questionnaire to all the parents. With the children, we are using actigraphy, where a watch is placed around their ankle for 7 days and nights, ideally, and so that we have a way to really look at the actigraphy data around the clock for 7 days. We're also asking parents to keep a sleep diary so that we can compare the actigraphy data with the sleep diary information. Interestingly, in this age children, for safety reasons, the watches need to be placed on the ankle. And what we have tried to also do is make them a little bit more appealing looking with using tape with gummy bears on. With our providers, we are just collecting information about their demographics, their training, and how long they've been practicing. Our qualitative interviews ask parents and providers about their perceptions of children's sleep, the sleep habits that they, if they're providers, we ask about, what habits and what patterns do they see in their patients, and what about bedtime routines and timing. We ask specifically about any problems or difficulties with sleep. And as Nancy mentioned, we really are asking people to tell us what they think would be helpful in terms of promoting healthier sleep. Because this is a mixed methods approach, we're going to be integrating both our quantitative and our qualitative findings. And we are, I'll be sharing with you some of our initial qualitative findings, but what I have found in the past when I've done these types of mixed method studies is that the qualitative descriptive findings oftentimes will give great insight to what you find out when you are using surveys, or certainly when we're looking at the sleep-wake patterns that we can see on children's actigraphy data. So we'll be using a descriptive analysis of the survey data and the actigraphy recorded sleep characteristics. We're using a descriptive qualitative approach. We transcribed all the interviews. We coded the interview data, both from parents and providers. We're using Atlas to manage our data. We have a coding group and a qualitative group of about 6 individuals, which has been very helpful. We're in the midst of a thematic analysis, and we are looking to describe and compare the patterns and the themes that we see both within and across our provider interviews as well as our parent interviews. So this is just another way to depict the way that we're integrating our quantitative and our qualitative findings to hopefully come up with some culturally and family-friendly approaches for healthy sleep. Once we come up with those with the help of our community advisory committee and our community partners, we will begin to put some interventions together, and as Nancy mentioned, we hope to begin to trial some of that in a very preliminary way. Again, using our committee, using our parents, using some of the stakeholders, either in individual sessions or focus group meetings, to check in with them about the intervention and whether it's working, how it's working, is it understandable, is it culturally sensitive, et cetera, et cetera. So the ongoing role of our Community Advisory Committee, we're in the process of this right now. As I mentioned, we're in the midst of data analysis, and we are about to meet with them and bringing our findings to them so that they can help us interpret the findings, maybe ask more questions, and think about what next steps might be from what we're hearing, both from the providers as well as the parents in the community. And so we are hoping to come up with some creative approaches for helping families to individualize approaches and integrating what we've learned from all of the participants who have been very generous with their time. The next steps that we hope to be able to do are testing these approaches in the community. And because this is a community engaged process, we have offered and will continue to offer co-authorship with our partners on manuscripts and any community publications that we've done. We have one manuscript out, and we did have some participation from our community partners as co-authors on that publication. Okay, so where we are today, we have engaged our community members. We have refined and developed and used our interview schedules. Because it's a qualitative interview, it keeps being refined, and that's perfectly within reason in terms of a qualitative approach. We've translated material into Spanish and have conducted some Spanish interviews with Spanish-speaking families, which then were translated into English for coding and for analysis. As I mentioned, we did reach saturation with our themes after interviewing 16 providers, and that included pediatricians, nurse practitioners, and registered nurses, all of whom were in active practice in various community health centers, as well as the primary care center at Yale New Haven Hospital. So far, we have interviewed and collected data from 21 parents, and that is an ongoing process. And we are in the midst of analyzing those data and need more data. So just to summarize a little bit about what we've learned so far, there's really quite remarkable agreement among all the parents we've interviewed and the providers about the importance of sleep for family members and young children. And there's a very high level of interest in addressing the issue, and I can give you more specifics on that. All providers, both child care providers and pediatric providers, really do see the need for increasing their own knowledge and skill, and parents' sleep knowledge and skill building on how to recognize sleep problems and trying out solutions. When we were interviewing, not so much the pediatric providers, but definitely the child care providers, they do the best they can. They get a lot of continuing education about the children they care for, but they only get sleep, in terms of the amount of information they get about sleep, it has to do with sleep safety and keeping infants safe in terms of not bed sharing and co-sleeping, etc. So really they don't get any information about other aspects of healthy sleep, and most of them are sort of using their own experience with raising their own children in terms of trying to help their parents that they work with and trying to give advice. Pediatric providers had more basic knowledge, but acknowledged that they really did need more information and would welcome more information about pediatric sleep. So the importance of the training and disseminating information is really something that we are hearing loudly and clearly. And we really have been able to understand that child care providers especially are crucial in doing this work. They are the people who see parents and children daily and have a much better chance to get to know each family's situation. Certainly pediatric providers have a number of visits, especially in infancy and toddlerhood, the well child visits that they conduct with parents and families. However, these are often constrained by time, and they are maybe every 2 to 3 months initially, then every 6 months, then every year. So clearly the child care providers who are working with parents on a daily basis seem to be a wonderful inroad into this issue. So what I'm going to tell you about now are some of the specific themes and sub-themes that we've begun to understand from our interviews. So in the provider interviews, we were able to sort of break that down into how providers understand their family sleep issues and children's sleep issues, and then what they advise, in terms of approaches that we might consider. So in terms of their understanding, they told us that it's really important to get to know each family, and one of our quotes is, with a listening ear, that many families that certainly who are in this community and are experiencing a lot of stress have many individualized kinds of things going on in their family, in their homes, in their communities, and it was important to try and get a sense of what was going on with each individual family that might affect sleep, might affect the children's sleep, might have to do with the home situation, the space, the environment, etc. Stressors that were particularly important that came out in this were maternal mental health stressors, safety of the household and neighborhood, and sometimes stressors that were just so overwhelming to the family that sleep became not so much a major concern, but a much lesser concern. So these would be stressors like homelessness. So not focusing so much on healthy sleep, but where are we going to sleep the next day. We also, in this section, looked at the importance of avoiding assumptions, or they told us about the importance of avoiding assumptions, that all families are unique, and it's important not to make assumptions about single-parent families, dual-parent families, but rather to try and get to know each family and find out what their patterns are, what their family traditions are, whether they use a family bed, and that's important to them, whether siblings are sleeping together, you know, who's in the bedrooms, and how is all that arranged. Another theme that came out is this interesting balance between nap times and bedtimes. And in child care centers, nap times are fairly well structured, and sometimes parents you know, whose children were in child care were confused or were a little bit irritated about nap times that happened during child care because they felt like, well, maybe if the children are napping so much during the day, that's interfering with their ability to go to bed at night. And so a lot of interesting information came out about the balance between the nap dilemma, or whether to nap, when to nap, how long to nap. And obviously that changes with the child's age and with their developmental needs. Another finding that we had found were that screens were everywhere, TV screens, iPads, laptops, phones, in bedrooms, in other rooms of the house. And while in many cases the providers told us that they thought that these screens really interfered greatly with sleep for both parents and children, in some cases they thought parents were likely using some of these screens, watching TV, having movies on, etc., as sort of a self-soothing or distracting mechanism, or as a way to screen out other environmental noises that they didn't want to listen to. So while screens are everywhere, we're also hoping that maybe we can use screens, specifically apps or websites, as ways in which we can help families with healthier sleep. Another pattern that came out of these interviews was that bedtime routines were an issue, and this was not just for the children, but it was around parents' bedtimes and what it was like for them trying to settle down and going to sleep. And so looking at ways in which we might think about providing templates or different ways to help a child to settle down, different templates that parents might consider for their own bedtime routines, helping parents recognize cues in children that they were getting sleepy and avoiding them getting into that overtired time and situation. The other thing that we were hearing is that parents might actually welcome earlier bedtimes for their children if it gave them more time for themselves or time to catch up with things that otherwise they weren't able to do. Negotiating bedtimes came through as a microcosm of parenting and parenting issues. Helping parents reframe healthy sleep routines and bedtimes as being not only helpful physically for their children in terms of their growth, their development, their brain growth, but also as a way to set some limits, to create a soothing time together, etc. Parent schedules and shift work were really something that came through as being very difficult. So there were some providers who described parents as having very little in terms of the way of schedules. They were not working outside the home, or their kids were not old enough to be in school yet, and so the family was not really on a strict schedule, and in that case, the providers saw the sleep schedules sort of being all over the place. Whereas other parents who were either working late shifts, working double shifts in some cases, would create really very challenging situations for young children who maybe needed to sleep at a relative's house and then be picked up in the middle of the night by the parent when they got off work. In one case, we had a provider talk about a parent of theirs who was a bus driver and had to get up at 4 in the morning to drive her bus, and the child, her toddler, had to get up at the same time and basically was with her in the bus in the car seat, sleeping as she was driving the bus. So lots of different constraints. We learned from teen parents, or the providers who serve teen parents, that they're in many cases unique and probably need a tailored approach to help them with this issue. They think differently, they reason differently, they are more likely to be living in their parents' home, most likely with a baby's grandmother, and so that clearly means a 3-generational approach to sleep and sleep routines is going to be probably most appropriate. And the teens that we heard about were spending even more time with screens than the adult parents that we heard about. From the parent interviews, and I just want to make a point that this is really preliminary because we're still conducting these interviews. We had some really interesting interviews where both parents were present, and there was clearly disagreement between mothers and fathers about bedtimes and when their young children should be in bed or shouldn't be in bed, or whether it was important to have a routine or not have a routine. There was also disagreement that the parents told us about between what the way they structured their children's bed patterns and bedtimes and what their children's pediatric providers advised them about in terms of having an earlier bedtime or trying to get their children down for naps so that they would have the sleep amount that was recommended for that age child. We heard about, or we're hearing about, common patterns of co-sleeping in the family bed. Some parents were fearful that if they talk about this, for example, to their pediatric providers, that they might be reported to Child Protective Services because everybody is very aware of the information about the dangers of co-sleeping with infants under the age of 12 months. But this was definitely something that we're hearing a lot about, both from providers and from families. Most parents were very quick to describe cranky behavior, irritable behavior, if their child doesn't have a good night's sleep, and so they are, in that way, very invested in thinking about how can we do this better, how can we help our child sleep more effectively. And parents were also describing a pattern that they saw in their children called fighting their sleep. So, the child trying to stay awake and getting crankier and crankier while being really, really tired. So I think that holds a lot of promise as well, because the parents are able to identify that kind of behavior as probably a time when the child maybe really needs to be put down for a bedtime and a bedtime routine. The providers also had lots of advice for us in terms of how we might get the word out about healthy sleep, both in terms of educating pediatric providers as well as child care providers, and how we might reach parents and the various ways we might approach that. Again, we are thinking that our first steps are probably going to be focused in child care centers and home-based child care providers because they have the structure, they have a wonderful population of parents who they know very well, and this just seems like a great first place to start. So we're going to try and probably use a train-the-trainer approach where we will train the child care providers to be the interventionists for the approach that we use with families. Our interviewees had lots and lots of ideas about ways in which we could try and get the word out and also coach and help parents with healthier sleep. Lots of them thought that electronic approaches would be useful, and we're also starting to hear that from parents as well. So apps on a smartphone or YouTube videos that might provide a template or demonstration of a bedtime routine for different aged children. Videos for teen parents to watch, etc. So lots of different ideas about electronic approaches. Also ideas about more community-based approaches, public service announcements. There's been so much success in getting the word out about safe sleep for infants. And so the thinking is that this might also be a way, using public service announcements and a campaign, to get out the word about healthy sleep for young children. Teaching approaches and face-to-face approaches were also recommended, and again, with the idea that one size does not fit all. So some providers and some parents were very much in favor of electronic approaches, but a lot of parents and a lot of providers also were saying, no, I need to be in a class, or I need to be able to talk to someone and ask my questions. So thinking about face-to-face teaching approaches, that would be helpful and useful. And again, thinking about the child care centers as a place to start, because these are community agencies that already have a built-in structure and in fact have continuing education opportunities as well as parent workshops. So that's, again, something that we're going to try and take advantage. Written materials were suggested to us, something for parents to take with them, to look at home, to put on the refrigerator, more going to bed board books to be able to use between parents and children. We have a Reach Out and Read program in New Haven, where parents of young children are provided age-appropriate board books at each pediatric visit when they bring their children in for care. And so this is something that could be coordinated, as well as more written materials for child care providers to have and to refer to. And then finally, just a few words about in-home assessment and interventions. The child care providers, some of the centers, especially early head start centers, have parent advocates who go into the homes, make home visits, and feel like this is a really wonderful way to be able to assess the sleep environment as well as the family's unique situation. I have to say, in our experience in working with home visiting in our other project, the Money to Baby program, this has been our experience as well, that getting to visit families in their home is a very wonderful way to learn their specific needs and the issues that they face. Here we go. Okay. So to sort of wrap this up, so our overall impressions, sleep is important, and that seems to be fairly well agreed upon. That we're learning there's not one size that fits all, that this requires a multidimensional effort. And in terms of thinking about how we're going to set up our train-the-trainer approach, giving people knowledge, making them aware of the issue, helping them with behavior, understanding behaviors, understanding attitudes, and then helping them to provide the education among a population of parents and supporting them in that way, and then also following up with those parents. So a variety of formats, and as I mentioned, looking at to start in the child care centers, and then going out from there. But our next step will definitely be working with child care. Yeah. So we're going to finish our thematic analysis. We will complete our data analysis from quantitative data, work some more with our committee, and elicit input into their input into our intervention, set up training materials, set up parent education materials, and then begin to pilot test the intervention. And eventually seek funding for a community-engaged randomized controlled trial. This is a project that represents one component of the program research, looking at improving sleep in young families who live within socioeconomic adversity. And I think, as Nancy initially mentioned, other related projects are Monica Ordway's funded project on sleep, stress, and health among toddlers living in socioeconomically disadvantaged homes, where she is measuring, taking biomarkers of toxic stress. She is doing sleep measures and collecting background and data from parents. And then we are finishing up a study with Barbara Caldwell that I think Nancy also mentioned in Newark, looking at parent perspectives on sleep among young children. So a similar kind of study from different parents responding to different cultural backgrounds, living in a different community. But I have to say, some of the very same types of themes and patterns that came through in those interviews. So sleep health interventions in primary care environments, we hope to move in that direction, using electronic, probably smartphone apps and technology to help parents not only learn how to help their children with healthier sleep, but also kind of provide boosters and ongoing coaching and contact, and using implementation science approaches. So I think that's our presentation, and we're happy to take questions from the participants.
Thank you, Lois. Thank you, Nancy. Let me just start off, and I think we already have a question or two, so just remind people to put that in the question and answer box. But let me begin. First of all, thank you, because it's a really nice example of community-based participatory research, and also a nice example of mixed methods from focus groups at one end of the continuum to actigraphy at the other. So nice to see. I wanted to get your thoughts about sort of the balance as you're beginning to see it. And I know this early conjecture because you're still in the process of collecting data, but how much of this is a problem of not knowing what to do, which is what a lot of our educational-based things, whether they're with primary care providers or others, are about, and how much of it is adherence to doing what you know is the quote right thing to do, especially, and that's, I think, related to some of your advocacy work about people in the homes and getting people, in there at night to help, especially disorganized parents, learn how to produce a bedtime routine, or parents who disagree about whether to put your child down early or late, or let them cry it out or not, those kinds of things. What's your sense of how much of this, in terms of where the change could potentially happen, and how much of it's a result of what we need to do in terms of skills training and what we need to do in terms of adherence or performance to those skills?
I think it's both. I think it's both, and one is prerequisite to the next. I mean, so what the families in this project and some of the smaller projects we did in Newark, for example, told us is that families think that this is very important. Most of them seem aware that sleep is important, right, and that having enough sleep, there is factual information they need, like how much sleep should you have, and things like that. But our, there was one study that we cited where they did a training in a Head Start program, which didn't have very sustained effects. And my suspicion for that is because they provided the information, that they didn't follow it up with the counseling and the adherence piece. Yep. People need problem solving. I mean, as Lois pointed out, each family is sort of unique and has their own sort of issues, and we're never going to change the fact that people live in environments that are not great environments, but we could help them to problem solve to make the environment more conducive to sleep. And so, but that's ongoing, it's like, so the adherence piece I think becomes very important. I mean, sleep, I have other projects that are about behavioral change in sleep, and it's like everything else. It's like anything else you adhere to. It's not enough to have the information. You need ongoing support, counseling, problem solving. Maybe there's a motivational interviewing approach that they need support. And so I hope that answered your question.
Yeah, it does.
Actually, if I could just add, I think that, just to add to what Nancy said, we are hearing, though, that there is some basic knowledge that we could really help parents understand better, and that will be a starting point. One healthcare provider had an example of parents had come in and they were complaining about the sleep and their young child, and it was news to them that they could set a bedtime and that they could set an earlier bedtime. And the provider kind of coached them about that and said, I want you to try this, go home, see what happens, and see if things, get any better. And, saw them back in 3 or 4 weeks. And the parents were like, it worked. It was a miracle. And it was a very simple intervention. And that they just weren't sort of thinking about, they could set that limit, and that was okay for them to do as parents. And, everyone was a lot happier in that particular family situation. I mean, that's a simplistic example, but it's one example of where, information is helpful, but I think it takes more than information. It's skills, and it's booster sessions, and it's counseling.
Yeah, it kind of argues for a step care model at some level, doesn't it?
Absolutely, that would be perfect. Yeah, it does.
Yeah. One quick question while we have a little time. One of the participants, attendees, asked about which data is coming from the child care providers versus the pediatricians, or are you combining that data in some way?
So we looked at, we did a within and across analysis, and did a sort of compare and contrast. And interestingly, we found that, well, I think I've already presented some of the findings. We found that the child care providers were much more likely to know families more intimately and sort of think about their specific issues and understand maybe their specific stresses because of their daily contact and the things that they would talk about on a daily basis. And they were doing some really impressive work with families. The healthcare providers were more likely to give sleep advice based on the general guidelines, the established guidelines. They were not as individualized or intensive as the work that the child care providers were trying to do, even though the child care folks needed a little more information to back them up. Healthcare providers were ultimately seen as having the authority. And this was sort of acknowledged by both groups. The child care providers would be very willing to refer parents to the child's pediatric provider if the parents really had an ongoing question or concern about their sleep. We found that healthcare providers seem to make more assumptions about families and not necessarily checking out those assumptions as well as the child care providers did. So there were some differences, but I would say there were many more overarching similarities than there were differences.
Yeah, thank you. If we can squeeze in 2 seconds, or another quick question, which has to do with whether there was any perceptions, awareness, knowledge, et cetera, about medical sleep disorders like obstructive sleep apnea.
So we asked about that, and essentially the healthcare providers would tell us that those are the kinds of things that for the most part they would try and refer their families to, but a lot of them didn't exactly know where to refer to. This was sort of an eye-opener for us, since there is a pediatric sleep clinic in the community. So we did have some information about that. In terms of the child care providers, they were totally happy to refer parents to their medical provider for any of those kinds of issues. And when we've asked parents about those issues, for the most part, we have gotten very little information about sort of diagnosed sleep concerns.
Yeah, okay, good. We've reached the end of our time. I want to thank both Drs. Redeker and Sadler for presenting and joining us today. Next month, our webinar will be on Tuesday, February the 27th, and it'll be Drs. Warren Bickel and Dr. Sam McClure discussing translational research programs on basic behavioral finding. So this concludes today's webinar. Thank you very much for attending.
Thank you. Thank you.
Thank you.